Nobody in Washington is talking about early heart disease prevention, detection, eradication. For some reason, the official cardiology, organizations have just dragged their feet on this topic. I mean, why you go get a colonoscopy, a mammogram, a pap smear, a prostate exam, and you don't get a heart calcium CT scan is beyond any possible logical explanation. Why wouldn't we want to know at age 40 that you got early atherosclerosis and wrap a lot of testing and behavioral education and nutrition education, fitness education? Why wouldn't we want to do that, for God's sake?
Hello and welcome back to the Vibrant Wellness Podcast. I'm Dr. Emmie Brown, here with the brilliant Melissa Gentile. Today, we're thrilled to welcome Dr. Joel Kahn, one of the world's top cardiologists. Dr. Joel Kahn has treated thousands of acute heart attacks during his career. He'd like all that to stop. He'd like to prevent all future heart attacks by breaking through to the public to educate and inspire a new holistic lifestyle. Having practiced traditional cardiology since 1983, it was only after his own commitment to a plant-based vegan diet that he truly began to delve into the realm of non-traditional diagnostic tools, prevention tactics, and nutrition-based recovery protocols. Dr. Kahn, thank you so much for being here.
I'm excited. Thank you.
Awesome. Well, thanks, Dr. Kahn, for being here. We're excited for the conversation today. So I want to start us out with, why is heart disease still the leading cause of death? And what do most people and even practitioners misunderstand about that?
Yeah, heart disease is the number one cause of death in most Western countries. It's been that way since 1918, 1919, 1920. It's a scary statistic that with all the effort we put into identifying the root causes of cardiovascular disease, and I think we still have much work to do on that topic, root causes of cardiovascular disease. We can spend an hour talking on one topic. Why do humans get heart attacks and monkeys and dogs generally don't? But let's not go down that path. There has been a change. In fact, just recently, the American Heart Association reported that although heart disease is still the number one cause of death in men and women, the number of deaths due to heart attacks actually has dropped a bit. You would hope so. There's less smokers. There's more, advanced diagnostic testing we can talk about. It's not being used enough, but it is being used some. There certainly are a whole lot of pharmaceutical treatments. Generally practitioners don't use the natural treatments, which is a shame, but at least they're using some treatment. But in place of dying of heart disease due to heart attack, there's more deaths due to high blood pressure. There's more deaths due to congestive heart failure, and there's more deaths due to what are called arrhythmias, or sudden, cessation of the heartbeat. So the overall number hasn't changed. The type of death has changed. Every 34 seconds, somebody in the United States dies of cardiovascular disease. Every 40 seconds, somebody has a heart attack in the United States. That number hasn't changed that much, although the survivability is better. And the statistic that I hate the most is 1,000 people a day in the United States die of something called SCD, sudden cardiac death. You can have this beautiful scene of your grandmother in bed, with her whole family around and beautiful hospice care, and everybody kisses and says goodbye. But the typical heart patient dies on the toilet with their pants down, and a family member comes in and they're blue and dead. And it's very graphic, but that's very true. That's sudden cardiac death. It's traumatic. It's ugly. It's painful. There's no goodbyes. That's what we got to make a big inroad on. And there's reasons people die suddenly. Usually it's badly clogged arteries that nobody knew about. So one of my, passions that I hope I'll have for many, many more years is to teach and actually practice, because I am a practicing cardiologist, the earliest possible detection of heart disease so we can intervene and prevent, 1,000 tragedies a day in the United States.
That's what we want. And on the note of maybe somebody had no clue they were headed down that path, Dr. Kahn, if I have no family or personal history of heart disease and I'm symptom-free, does prevention still matter? Should I care? And really, beyond screening basic lipids, does it matter for somebody without a history, and why is early detection so critical? I mean, you spoke to that just now.
Yeah, there's many layers, but just succinctly, symptoms in heart disease are very advanced findings. You can take a heart artery, which I always like a little model, nice and clean. Everybody can guarantee at birth. And you can badly, badly block a heart artery and still play pickleball and not know it, and still go downhill skiing and not know it, and still travel, into remote parts of the world and not know it. Sometimes there'll be that awful distress we call angina pectoris or angina pectoris, or shortness of breath or fatigue or palpitations. But those are very often very, very end stage findings. So you walk on the pickleball court feeling good and not knowing that 2 or 3 of your heart arteries are pretty badly blocked and a bad event can happen. So yes, the absence of symptoms is always of note, but absolutely not a reason to pursue more advanced testing. And then secondly, yes, routine labs. I mean, I yawn when I hate to say it, I love you internal medicine and family practice doctors, and even my colleagues, cardiologists, when I see those labs that they're getting, they're the same labs that we were getting 30 years ago, a comprehensive metabolic panel and a CBC and maybe a TSH, and maybe that's it, But there's so many causes of cardiovascular disease that go beyond. The Framingham study in 1961 started to identify high blood pressure, diabetes, high cholesterol, LDL, smoking history, and mom, dad, brother, sister having an early heart attack, stroke, or death is the big 5. But, you got to add 20 on nowadays. Some people would say 200 on, but even if you add 20 on, lipoprotein A, homocysteine, all the inflammatory markers, all the insulin-resistant markers, all the vitamin levels. And then let's talk about genetics and, the need for great genetic panels. And then and only then can you kind of get a big picture of you as a person and what risk are you at. You have to go deeper than what I'd call superficial annual exams, even at prestigious places, Mayo Clinic, Cleveland Clinic. You got to go deeper.
Is that what your basic screening panel looks like for heart disease?
Yeah.
Is it that comprehensive?
Yeah. If there's only one message people listen to, and I can take credit for everything, but most of what I know, like most of us, is from training and, being on the shoulders of giants kind of thing, that, the best screening test for atherosclerosis is to look at an artery. It sounds so simple. I mean, the American Heart Association has a risk predictor. They have a new one called Prevent. It's not bad. It actually gives you a 30-year prediction. That's kind of new and novel of a young person's risk of heart disease. 30 years is better than 10 years. And the Framingham study has a risk calculator, and there's a bunch of them online. But ultimately, you only really need 1 or 2 tests. What do your carotid arteries look like? That can be done by ultrasound, clean, mild, advanced. That's something we do in my clinic in Detroit all the time. And then finally, you need some kind of heart test. And the best test, unfortunately, is a CT scan. I wish it didn't involve radiation, but it's a very low dose of exposure. And the basic one is called a coronary artery calcium scan. If you're in my clinic and you're over 35 to 38, although I had a patient today, 33 years old, that had one, I didn't order it. That's a little young for a coronary artery calcium CT scan. You're going to get a number, your coronary artery calcium score. And if you're 0, we're on a good track. And if you're young, you need to keep an eye on it and repeat that maybe every 5-6 years. If you're 78 years old and you're a 0, we're going to have a real happy party and probably never repeat it. And at least get that basic number. Are you a 0? Are you a 50? Are you a 100? Are you a 300? I told a guy today in the clinic, his calcium score was 500. He's 59 years old. I always have all these links open when I see patients. You can put in your coronary artery calcium score. That's a 5-second, $100 CT scan with no injection, less radiation or equivalent to a mammogram. And you may only do it once in your whole life. And I calculated for him that his arteries at age 59 were like an 81-year-old. That finally caught his attention. There was really nothing. I said, you're 81 years old inside. How long do you think you're going to live if you're already 81 inside it? We have all these others, age tests. How quick can you get up off the floor? That's one that was just in the news. What's your grip strength? muscle is the organ of longevity, says everybody on Instagram. I say BS to all that. What's your artery age? And if your artery age is very young, you got a good shot because your arteries are going to every organ in your body. Young arteries, good brain, young arteries, good sex organs, good kidneys, good lungs, obviously good heart. So you've got to know and start with that. And if you showed me, look, my calcium score is 0, do I need 25 extra labs? We could actually argue maybe yes, maybe no, because you can't get any better than that. But I'd still do the labs. And that is pretty much my basic panel, vitamin levels, inflammation levels, insulin resistant levels, genetics, advanced cholesterol. Has to be lipoprotein little a just because it's so common, but it's not the only factor out there.
I'm just curious, Dr. Kahn, for your 35 to 38-year-olds, you're thinking about a calcium score. Is there any coverage for this in terms of insurance? I imagine.
Sweet and sour news, generally no. There's a fascinating documentary, if anybody wants to go geekish on this, called The Widowmaker Movie, about 10 years old. And it's the history of how this heart CT test was developed, the research behind it, and the fact that right now, I think 2 states in the United States cover it through insurance programs, Texas and New Mexico. Texas was the first, but that means 48 states don't. The good news is it's about a $75 to $150 test out of pocket. Maybe you can use your HSA or your FSA, but it's not going to hurt you too much to have the test, at least financially. So there's really you do need a prescription from a doctor, and that can be the biggest obstacle is a doctor arguing with you. And I'm not exactly saying every 38-year-old needs this test, but if I saw a 38-year-old that was worried and had a lot of lab and lifestyle and family history risk factors, it may be useful to reassure them. It's not a complete reassurance. It's a pretty good one. And it may be useful to diagnose early heart disease. I certainly do have people in their 30s that we've absolutely documented atherosclerosis because we know it starts in your 20s, maybe in your late teens, sadly.
Mm-hmm. And Dr. Kahn, when it comes to functional cardiology and conventional cardiology and the differences here, what are some of those key differences when it comes to prevention and even the treatment protocols that you're recommending for some patients?
Well, functional cardiology is still such a small field. There's so few of us, that, I've been formally trained. I'm certified. I spent a lot of time and a lot of hours in classrooms. But somebody could learn on their own by lots of reading and textbooks and all. But, you got to know nutrition and fitness and sleep and stress and supplements and vitamins and labs and, follow up and all. It almost needs to be its own subspecialty, but it's not recognized at that. Call it advanced preventive cardiology might get a little attention. And really our tools in standard cardiology, we got our routine lab panels. Frankly, cardiologists generally don't like to order labs. It takes time. Then you got to review them. Then you got to communicate with a patient. 10% of my life, it'll say on my tombstone, 10% of his life was emailing patients' lab results. There's no doubt about it. Sometimes more than I spend with my family. And that's usually at like 5:45 in the morning. I'm cleaning out my inbox of overnight labs. You've got to follow up on them. You got to have insight. It's not easy. And it's usually not reimbursed time. It's just important time. So most cardiologists don't like to do any labs, or it's going to be pretty basic. There's wonderful exceptions. 2, our tools are aspirin and statins. And of course, if needed, blood pressure, blood sugar, heart failure drugs. But certainly the supplement world, even one as simple as coenzyme Q10 or vitamin D or omega-3 are pretty underutilized, to say the least. And of course, you could go on and on about supplements that actually have scientific studies for the endothelium, the glycocalyx, insulin resistance, cholesterol control, hypertension control. My patients come to me because they want to get off of blood pressure, cholesterol, diabetes meds. And some of them can using food programs, scientific food programs. We do a lot in my clinic with fasting and the fasting mimicking diet, the 5-day program.
Is that the Prolon kit?
Right. They have a formal program led by a former Harvard professor, Dr. William Su, that helps diabetic patients strive to diminish their need for medication, type 2 diabetics, and lower their hemoglobin A1C. And, it's one of the great examples of food is medicine, but it works for atherosclerosis, it works for hypertension, it works for erectile dysfunction. Food really can be a powerful tool. So it's, applying all those tools. And if I have to write a prescription, I write a prescription. But, I'm the opposite of what I sometimes criticize blind cardiology, looking at lab. I mean, I want to know calcium scores and carotid pathology. And then I'm very aggressive about, and I didn't used to be, ordering coronary CT angiograms, which is the calcium score, but stepping it up to injecting iodine dye. And now with the artificial intelligence interpretation, we really can tell a patient. The paradigm is the cancer patient. God forbid you get called back, your PSA is high, your mammogram's abnormal, your pap smear's abnormal. You're going to see 3 specialists and you're going to get PET scans and ultrasounds and MRIs and biopsies, and you're going to be staged, hopefully stage 1 or something. But, you get a calcium score of 500, which is wickedly abnormal. You've got bad disease. And here's your aspirin, statin, and I'll see you in a year. No, let's tackle heart disease like cancer. Let's stage it. That's what that coronary CT angiogram with artificial intelligence, often called Clearly Health CT angiography. It allows it. It's, sometimes cash pay. It's definitely more expensive than a calcium score. It's a little more involved, and it does expose the patient to more radiation. But the wealth of precision, you have a 38% blockage, and it's not affecting your blood flow, and it's 60% soft plaque and 40% hard plaque. And compared to the one 3 years ago, because this technology has been out now about 4.5 years. So we have this ability now to diagnose and track coronary artery disease. We can't do it yet for carotid or leg arteries with the precision we can do it for heart arteries, but it's fundamentally changed my practice to, such a intense information-based, hopefully very accurate, approach to coronary disease management, prevention, and hopefully reversal. That's the ultimate goal. Reverse, reverse, reverse.
Because my understanding is clearly can catch those low-risk plaques. You said those soft plaques. Are you choosing that if feasible for patients over the coronary calcium scan?
Usually not step 1, because if you and there's an argument to be made, but got to remember $100 versus as much as $1,700. Low dose radiation versus now we're talking medium dose radiation. You got to have good kidneys and no iodine allergy and a low heart rate for a clearly CT. So there's parameters there. But I find when you present it to a patient, because I don't own a CT scanner, so there's no skin in the game, they very often decide, I want to do that. I want the most accurate test on the planet, particularly when you give them what I think is a very authentic analogy to cancer evaluation. They get it right away. And they say, I want you to stage my heart disease. So it's actually not to upend you, but the low-risk plaque is the hard calcified plaque. And it's not no risk, it's just somewhat lower risk. The higher risk plaque is non-calcified. It's a little younger, more unstable. And there actually is a third kind called low density. And when you see that on a scan, you really got to worry if the patient's serious trouble, more antiplatelet agents and everything you can do to keep them calm.
And that clearly differentiates between those three, as opposed to you don't get that differentiation with the.
You don't get it on even heart catheterization, the invasive procedure I did on thousands of patients for 25 plus years. I don't do it anymore. You really can't characterize soft versus hard plaque, or at least you can't quantify it. You can't do it you can do it a little bit in the neck if you do an ultrasound on the carotids. But this AI coronary CT angiography, where you can actually see how much plaque, where it is, and what kind of plaque, and track it over time, it's being tested, to be scientific. The company and I think the NIH have come up with a lot of money to do a 7,000 patient prospective study called Transform. And they're actually halfway through. And all the patients get a coronary CT angiogram. These are just patients with risk factors. Half of them don't get the results. half of the doctors don't get the results and the other half do. And they're going to manage those that get the results aggressively based on the results. And the other half are going to be managed in a standard way. And they're going to look at the outcome, within a couple of years. Does aggressive plaque characterization reduce events? And if it doesn't, we'll probably utilize these less. But
sure, reevaluate. Okay. Well, lots to think about there. I'm glad that we jumped into that a little bit. That was further down in our conversation. You mentioned the glycocalyx. I'd love to touch on that briefly before we jump into diet a little bit more.
Yeah, it's a fascinating field. Of course, in every artery, there's a lining, 50,000 miles of arteries in the body. I think some people have said if you took out, and every millimeter of the arteries is lined by single cells called the endothelium. I think I've heard if you were to take them out and lay it out, it would be like 8 tennis courts worth of surface area inside our arteries. Just, now you got to say 15 pickleball courts because nobody knows what tennis is anymore. But old school. But on top of the endothelial cells is a mucousy polysaccharide layer that it's been in the scientific literature for decades, the EG, the endothelial glycocalyx. And the concept is that a healthy glycocalyx protects a healthy endothelium, and you get nitric oxide, and you get relaxed arteries, vasodilatation, you get improved blood flow, you get less risk of plaque rupture and blood clots. The problem with all of that, great science, and it's definitely, the real deal, is in clinical practice, there's not yet a good blood test to say my glycocalyx is sick or my glycocalyx is healthy. And there's really not a really widely available imaging study. There is some strange device a few clinics have where it takes a picture of some capillaries under your tongue. And if you magnify it enough, you can actually make a measurement. But it's not widely available, to say the least. So there are companies trying to develop lab tests where you could tell a patient this is consistent with a sick glycocalyx. Pretty much all the things that we know aren't good for you, the smoking, the fried food, the sedentary lifestyle, the poor sleep, high inflammation levels, which are all bad for the endothelium, are going to be bad for the glycocalyx. And strangely, as you may know, there are some nutraceuticals of seaweed constitution that do seem to protect the glycocalyx. So I've never seen anything about dietary seaweed protecting the glycocalyx, but purified, capsules of seaweed and other natural products have, shown clinical benefit, and I use them in my clinic.
What brands are you using?
Well,
if you don't mind.
Yeah, I'm pretty exclusively, when we're talking about glycocalyx, Calroy, and the product they have called Arterysil, which has been around for about 5 years. And to their credit, they're not a giant, vitamin company. They dedicate a lot of money, as far as I can tell, to research and basic research and some clinical studies. And that's impressive because, a lot of the supplements we have, we can't really point to a peer-reviewed paper.
100%.
So let's dive into diet a little bit, and maybe this is a provocative piece. Not that we want to provoke folks on the show, but I found this fascinating. Last year, the University of Pittsburgh School of Medicine researched a molecular mechanism by which high-protein diets could increase atherosclerosis risk.
Right.
So I'm wondering, what's your perspective on high-protein diets? It's really all the rage, and it's being kind of touted as a panacea for metabolic woes.
Yeah. And as it says, it's like point counterpoint. There's that famous old analogy. I think it's called the 7 blind men and the elephant. Maybe people have seen that. But, 7 people touching an elephant, and the one touching the tail says it feels like a rope, and the one touching the trunk says it feels like a snake, and everybody's blind. And right now I feel that way about nutrition. Muscle is the organ of longevity, and therefore animal protein is the food of longevity. And that's one blind person, in my opinion. And, I don't know, the next person is feeling fiber, and, fiber is the food of longevity. And, other people, it's balance and grip strength and, how far you can carry water-filled buckets and farmers carry. There's all kind, and then, of course, all the biological testing for your for your age, and everybody bragging they're 25 years younger than their driver's license. And it is, ultimately, I think it is vascular age goes on the top. It's the most important because we are dying of strokes and heart attacks and chronic kidney disease and, peripheral disease and amputations and suffering sexual dysfunction from vascular disease. So, I mean, to have big muscles and not know your calcium score is, to me, blind, faith. And there obviously are bodybuilders that are using supplements and steroids that are just outright dangerous, and they don't have a good longevity. Frankly, most of the longevity pockets of the world, whether you want to call them blue zones or not, you're not full of muscle-bound people. They're full of, little people that know how to get up and down a hill pretty good at an elderly age, but they're not really focused. So this hypothesis that really being ripped and having, a high percentage of muscle in the body and a low fat percentage, is not completely tested long term. So I always go back on this topic to my favorite scientist, who I also personally believe is the number one nutrition scientist in America, maybe the world, Walter Longo, and PhD at University of Southern California and at a Cancer Institute in Milan, half a year split. And he wrote a book, I think it was 2018, The Longevity Diet, where he proposed this concept, and people have trouble understanding it, but he calls it the 5 pillars of longevity. That you can't take 2 studies or 4 studies and say, upping your animal protein intake has been shown in this, group of 20 volunteers to result in whatever you want to say it resulted. You got to take 100 years of nutrition science. You got to take hundreds and hundreds, if not thousands, of studies. And he divides to studies that he calls them juvenatology or basic science studies. Now, doesn't make sense that more meat promotes longevity at the basic science level. That's usually talking about mTOR, for example. Then he talks about randomized clinical studies, of which there's not that many in nutrition. The Predimed study and some others. There are, but there's not that. And then he talks about epidemiology, which is 90% of all nutrition data that everybody hates because we know that correlation does not prove causation. But if 25 studies in a row correlate the same thing with the same outcome, it might be causation. You have to look at them all. And then he talks about centenarian studies. What do elderly people do for nutrition? You can't ignore that topic. And then the final thing is a very complex one. It's called complex systems. Like he talks about cars rust, and that's oxidative stress, and bodies rust, and we call that oxidative stress. And you got to look at a higher level. How does a plane break down? How does a car break down? It's really a very cerebral construct. But, it's very different than Instagram, which I'm involved in. But,
does he have an Instagram? That's the question.
One study of the day. And, I'm a bit of a hard ass on Instagram because some people will post, a PubMed code for the statement there, and I'll go over there and check it, and it's like a 45-year-old dog study for 5 minutes, and that's what you're
irrelevant.
You're telling 1 million people is a proven fact is a 40-year-old dog study that lasted. So we all got to be careful, but when you put all that together, there's ample data to say it appears that a lower protein diet with an emphasis on whole plant foods is a very smart strategy. And around age 65 or 70, based on not perfect data, but some data in humans from Harvard with Morgan Levine and Dr. Longo, that around age 65 or 70, to avoid frailty, you may be upping your protein intake. It could be more beans and peas and lentils and tempeh and tofu and nuts and seeds. It could be adding in foods you hadn't eaten your first 65, 70 years, like fish or fish. I wouldn't say more than that. It shouldn't be seafood. It could be a very high quality protein powder. Of course, most of them are untested in scientific trials, and some have problems with purity and heavy metals, and you got to be a bit snobby and cautious. The cardiology literature is all about whole food plant-based diets. It's just impossible to deny that. And every week there's new studies. This week there's a brand new study on plant-based diets reducing acid load on the kidneys and the inflammation system and promoting better weight loss than non-plant-based diets. It's a randomized study. It's a beautiful study, just got published this week. So you got to take, that's all part of the 5 pillars of nutritional longevity, which everybody should school themselves to understand.
And when we're talking plant-based diets, we oftentimes think about seed oils. And I think there's a lot of processed vegan foods out there that people rely on, unfortunately, but we demonize seed oils. And so I'm wondering, what is your perspective on this? Are they as inflammatory as the wellness industry says they are?
Yeah, I have had the pleasure of being the fall guy at a few famous debates. In 2014, I was on stage with Mark Hyman and Frank Lipman, and we were being interviewed at a Mind Body Green retreat, which is a website. And we were asked, who of you 3 likes gluten? I raised my hand because I think whole grains are amazing based on science studies. If you don't have celiac and you aren't gluten sensitive, eat whole grains. Of course, whole grains have gluten in them largely. And, it brought the house down and people were throwing tomatoes at me. But I know the studies. So at the end of the day, it was an authentic and honest statement. And I think that's where you want to talk about protein. We got a dogfight going on social media. You want to talk about cholesterol matters, doesn't matter. On social media, we got a dogfight. We don't have a dogfight in the academic world. There's nearly 100% consensus that in patients with proven atherosclerotic vascular disease, a lower LDL is protective. And it's not the fireman, it's the fire, as Gary Brecka said incorrectly on the Joe Rogan show a couple of months ago and confused 30 million people. But the seed oil is the third, pillar of this crazy stool, and stool would be a good word for this whole conversation, because there's been data for decades that omega-6 rich vegetable oils don't automatically cause disease and inflammation. Now, let me just declaration. Come to my house, walk through my pantry, look at my kitchen. You're not going to see corn oil or soybean oil, and we don't carry in processed vegan foods, nor do, if we weren't vegan, we don't carry in processed foods of any kind. They all are, poor quality choices, no doubt. And that's where everybody agrees, highly processed and fast food and frozen food. And now we got to talk about plastic wrap food and microwave food. And, we got to talk more about advanced glycation end products, which are very high in all processed food, plant-based and meat-based and all. But seed oils of themselves, a bottle of organic canola oil is not in and of itself pro-atherosclerotic. In fact, everybody's got to go back to 1996 and recall a very famous randomized study in the cardiology world called the Lyon Heart Trial, Lyon, a city in France, where they substituted for butter canola oil margarine, and cardiovascular rates dropped 72% compared to butter. And they stopped the trial early because the seed oil arm, which was canola oil, was so dramatically superior to the butter fat arm. And it's just a famous study, and there's many others. So I don't teach people to gravitate to seed oil because they are getting most of it in processed food, fast food, gas station food, ballpark food. No, it's all garbage. But to single out the seed oil and not the salt and not the refined white carb and not the added sugar and not the red dye number 40 until recently, and all the other components, it's just junk, And
the quality, right, Doctor? You said organic canola oil.
I had a period, I owned several restaurants and I have many patients that own restaurants. And, if you have a fryer in the restaurant, ask, when's the last time you change that oil? And do you have a filter in there for that oil? And it's very common to go 7, 10, 12 days and it's the same oil. Well, you wouldn't do that in your house. So I used to love falafel. I just don't eat it anymore because it's cooked in oil that's been sitting there for ungodly periods of time. So seed oils have gotten abused. I don't know why. I'm a big fan of Robert Kennedy Jr. and the Make America Healthy, kind of mission and what he's doing for children. But, this idea that, seed oils are evil and beef tallow is, the gospel is, it's just wrong. It's crazy and inverted representation of, most of the science, the 5-pillar science.
What about homemade falafel, Dr. Kahn?
You can bake falafel. You could just put some oil of your choice, and you can cook with olive oil. It doesn't have the world's highest smoke point, but it's perfectly fine to. You made some nice little falafel and popped them in a pan in your house with extra virgin olive oil. It'd be a delicious food to eat. I would bake them if you have your choice. One of the most under-discussed nutrition topics is advanced glycation end products. Take a food rich in protein and fat, which is most meats, cheeses, and cook them at high, dry temperature, whether that's grilling, barbecuing, frying, roasting, and you create a chemical reaction called the Maillard reaction, and you create pro-diabetes, pro-dementia, pro-cancer, pro-heart disease series of chemicals, and they get in your tissues throughout your body. And there are ways to actually measure levels of advanced glycation end products. And if you do water-based cooking and sautéing and soups and chilies and tagines, and even if you just marinate the meats that you're going to cook at higher temperature, you greatly reduce the process. So that's why I'm not even a big fan of, bake a falafel versus fry a falafel. There's a big difference ultimately. You got to also enjoy food, and there's that aspect at the end of the day. But I can perfectly enjoy a baked falafel as long as we're talking about falafel.
Yeah, it's interesting you mentioned that because I've seen a lot just in the media recently about like water-based cooking methods and in other cultures and how it's related to their aging. So it is interesting, but I'm curious to know, are there any other trends or just common advice that concern you in today's wellness or cardiology space?
Everything.
I know, right? It's hard.
We are, I'm writing a book right now, and I have been invited to a Vibrant Wellness, a retreat, and then later this year. And my topic is always a war on heart attacks. Let's get fired up. About 1,000 people a day dropping dead. Yet we have the lab panels. Your company makes a great one, and others are available through some other vendors. We have lab panels to detect, many factors that lead to heart disease. We have the imaging studies available widely all over the United States and the Western world. Nobody in Washington is talking about early heart disease prevention, detection, eradication. For some reason, the official cardiology, organizations have just dragged their feet on this topic. I mean, why you go get a colonoscopy, a mammogram, a pap smear, a prostate exam, and you don't get a heart calcium CT scan is beyond any possible logical explanation. Why wouldn't we want to know at age 40 that you got early atherosclerosis and, wrap a lot of testing and behavioral education and nutrition education and fitness education? Why wouldn't we want to do that, for God's sake?
Maybe for the average patient or person listening in, like what should we be asking for? Even if we're asymptomatic, even if we're young, like what's something we can do that's a bit proactive, maybe with our general healthcare provider?
Yeah, from certainly age 40, 45 up, do ask. There's my own prescription pad, but ask. That's what it is. CT, calcium scoring without contrast. But you generally may have a little battle with your primary care doc. You might even have a battle with a cardiologist. But any, a nurse practitioner, a PA, you do want to do that. You don't want to do it often. I do occasionally come across people that are having it yearly. There's just no reason. You do have to have a discussion about radiation exposure. There just was. I'm very open about it. There was a paper in JAMA, a major journal, about 2 months ago, that it could be, there's 93 million CT scans a year in the United States, that it could be possibly, it was a projection, a model, that up to 5% of cancers down the road may one day come from heart and body, more body than heart actually, CT studies. So particularly in children where they have their whole life ahead of them, be cautious, but given the burden of heart disease, get the test done once, maybe 10 years later. And then ask for some extra labs, or find somebody that knows about Vibrant Wellness, or go to one of these new companies where you can get 105 tests for, $400 or $500. There's a series of them, and I'm sure they're going to grow. And find out, what's my homocysteine, what's my omega-3, what's my vitamin D, what's my, high sensitivity C-reactive protein. And frankly, now you can put all these things in a AI, search engine and learn so much I'll do that sometimes. Patients will go through their labs and say, well, you didn't talk about the high sensitivity troponin. I'll go over to Grok or something and just put in, and I'll just cut and paste, because the answers are actually pretty good. It's not that I don't know the answer. I know the answer, but it's nicely said and preformed and simple. So, we have access to so much reasonably reliable information for patients now.
You say cholesterol still matters, and you briefly touched on this earlier, but I wanted to clarify. Are you talking about that basic panel, the total cholesterol? You said LDL still matters. Of course, we want it to be lower. Can you elaborate a little bit more? Maybe speak to triglycerides. I know that's still a huge risk factor that the functional medicine community does prioritize also.
Well, I mean, I'll be concise, but, there are some really interesting observations that fit into the functional world. And, one is, and I brought it up, I think, early in our conversation, is why humans are so prone to atherosclerosis. By age 18 and 20, you do an ultrasound on a human in the United States, you'll see plaque in a lot of people. We're so prone to developing this disease. And over time, it gets to the point that it's often very clinically serious or even fatal. And there is a reasonable question, why are humans so prone to it? And, in modern life with stress and Wi-Fi and EMF and our food supply and our water supply and microplastics, there's so many answers to that question. But even if you go back 20 years, 30 years when life, in terms of some of those factors, wasn't as obvious, there wasn't as much EMF and Wi-Fi 25, 30 years ago. One basic, really interesting observation is 99+% of all animals on the planet make their own supply of vitamin C. It's a very simple biochemical reaction. Here's glucose, here's your liver, boom, 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 you make vitamin C. And still a theory proposed by the great Linus Pauling, 2 Nobel Prize winner, that, the unified theory, that's a paper he wrote in 2002, I think. The unified theory of cardiovascular disease is vitamin C underproduction. And, the word ascorbate comes from the word scurvy, that we get just enough vitamin C in our supplements, low dose supplements and foods to prevent scurvy. But we don't make anywhere near the amount of vitamin C we'd make if we could turn on the GLO production line in our liver, which one day CRISPR technology may actually allow us to turn it on and we recover our vitamin C production. And that, the undersupply of vitamin C is the root cause of cardiovascular disease. Very provocative. It actually makes incredible sense. It's just limited in terms of, actual trial data. So I do use a lot of vitamin C in my clinic. That's one observation. Number two, so the reason I bring that up, there is a debate. Your LDL cholesterol is high. Can it just cross the glycocalyx and the endothelium, maybe spaces between endothelial cells? Can the cholesterol get into the what's called subintimal space, incite some inflammation, macrophage accumulation, and start plaque production? Or does it require, and therefore the more LDL in your blood, the more likely there's going to be entry passively of LDL into your subintimal space. And the other one is lipoprotein A. It really, lipoprotein A is a major factor in atherosclerosis. Everybody, cholesterol doesn't matter. You're going to tell me lipoprotein A doesn't matter? I'll line up my 35-year-old patients that have all had heart attacks because of lipoprotein A, and they'll shout you down. It matters a lot. So versus the endothelium is damaged and cholesterol's coming, and that's, again, gets back to kind of Joe Rogan level of science. I love Joe Rogan. I've been on his show, but it's not exactly, academic seminar that necessarily goes on there. But you have injured endothelium, and injured endothelium allows the passive transfer of cholesterol. Maybe cholesterol's coming to repair. There is a theory that lipoprotein A does accumulate at damaged endothelium with a repair function, but it all backfires because it's loaded with all these toxic oxidized particles and LDL cholesterol. So there's that debate. But no matter what is the original cause, is it a healthy artery just taking up cholesterol and lipoprotein A? Is it a damaged artery? The higher the concentration of the blood of LDL cholesterol and lipoprotein A, the more entry into the vascular wall. And it doesn't mean don't try and make the vascular wall stronger. with good exercise and good nutrition and maybe lots of vitamin C and don't smoke and avoid toxins. But there's classic articles written in the cardiology literature. It's the cholesterol stupid. That's actually the title of a very famous editorial by the number one cardiac pathologist in the world, William Roberts, MD, who handled more hearts and more arteries than almost anybody on the planet. It's the cholesterol stupid. And he basically had the premise, and I agree. If you have a high blood pressure and a very low LDL, you're probably not going to get plaque. If you have a high blood sugar and a very low LDL, you're probably not going to get plaque. And if I say LDL, I want to say lipoprotein A cholesterol too. If you have very high glucose, I think I said that, it's the cholesterol stupid. And there, and ultimately the last thing to say is cholesterol, LDL, and lipoprotein A, they are risk factors. You can smoke and not get lung cancer. That really destroys the argument that smoking causes lung cancer, but we don't throw that idea out. We just know it isn't a one-to-one. It may increase the risk of lung cancer 20 times, but it doesn't mean everybody gets lung cancer. And it's unfortunately very confusing when I have two people in my clinic and they both have total cholesterols of 300 and LDLs of 200, and one has a calcium score of 800 and one has a calcium score of 0. It's admittedly very confusing, but it is ultimately a risk factor. And maybe one person just does have a diet that's allowed them to have very strong and very intact endothelium. And there just is very little uptake of that high LDL into the subintimal space. And the other person has a damaged endothelium. That remains unclear, but the number of particles of LDL and lipoprotein A in the blood clearly correlate. And when you bring them down, it doesn't matter if you bring them down with ileal bypass surgery, bring them down with all the prescription drugs in the world, bring them down with diet and lifestyle. The more you bring it down in a patient with some disease, the more you lower their risk. There's no question about it. 115 years of science behind all that. It's almost like the 5 pillars discussion of nutrition. There's a similar 5 pillars discussion of the role of elevated LDL cholesterol and atherosclerosis.
I have to ask quickly, Dr. Kahn, before we wrap up, the lipoprotein A, LP little a, we also refer to it this way. How do we lower this, as it's primarily genetically influenced, is my understanding, and there's some debate as far as can we lower it? What do you do?
So first of all, shameless plug, read the book. I wrote it. It's the only book.
Look at the title. There we go.
Book on lipoprotein A in the world right now. There should be others.
Yes.
Right now I own the title. There is no FDA-approved drug for lipoprotein A. Novartis, big company out of Switzerland, is about a year away from hopefully releasing the first one if they hit their clinical trial endpoints and the FDA approves it. It'll be very expensive. It'll be injection. It'll be limited to people with previous bypass, strokes, heart attacks, and stents. It's not going to be approved through insurance companies for the general public. And then 2 other companies have very large trials ongoing, Amgen and Lilly. So in the next 10 years, but 10 years is a long time for these patients, there will be several, I believe, FDA-approved drugs. I still think they're not going to be for the public because they're going to be name brand, patent protected, very expensive. It'll be 15 to 20 years before there's, generic low-cost lipoprotein A lowering FDA-approved drugs like there are statins now that cost pennies a day. In the meantime, if it's insanely high level, there is a odd treatment called LDL pheresis. It's like dialysis, and it sucks the LDL out of your blood into a filter, and it also sucks lipoprotein A out. There's about 1,500 people in the United States that are being treated that way. It's insurance covered, usually people that have already had bypass, heart attacks, and stents. Major universities offer it. That's exotic. They do it much more in Europe than they do in the United States, LDL pheresis. Statins don't work. Statins lower cholesterol and LDL cholesterol. They actually raise lipoprotein A. And if clinicians would start measuring lipoprotein A routinely in their patient on statins, if they had a baseline, they're going to see it go up. If they didn't have a baseline, about 25% of people will be quite high. I still use in my clinic a fair amount of niacin. Niacin in cardiology is like saying seed oil in Washington, D.C. People will want to throw rocks at you. Niacin was proven in the 1970s to lower the risk of heart attack, stroke, and actually all-cause death in a famous study called the Coronary Drug Project. And then it fell out of favor as statins got more popular. And I think for a few years, niacin has a role. I think ultimately there'll be prescription drugs that have big outcome studies. But, you can lower lipoprotein A 50, 60, 70, 80%. We just don't have an outcomes trial because the ones that were done in the 70s were not checking lipoprotein little a. They were just being done for your general cholesterol panel.
Very helpful. Thank you so much.
Yeah, thanks for breaking that all down. I know we're going a little bit past the hour here, but we really appreciate the insights and everything. We're really excited to have you at Longevity Summit in September. And where can we find you online if you want to learn more about either your work or your practice or even your book?
Yeah, I do have clinics in Detroit, and in the winter I migrate down to Florida because I'm old and weak and don't like snow anymore. Boca Raton in my And all that's found at www.drjoelkahn.com, drjoelkahn.com. I have a weekly podcast and clinics. I do see a lot of patients, new patients, licensed in about 20 states, so I can do telemedicine in all the big states like Texas. And, Instagram, TikTok, Twitter. Not on LinkedIn. They kicked me off LinkedIn for the fourth time for posting COVID research.
Oh, no.
LinkedIn is like, if you're listening, anybody who works for LinkedIn, they're the worst than any other. Anyway, so you can't find me on LinkedIn right now. I have to make up an email and get back on LinkedIn.
Well, we'll link everything else down below for you guys. And thank you, Dr. Kahn. I really appreciate it so much. And until next week, wishing us all vibrant health and wellness.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. And just a reminder, this podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.